Welcome to Unremarkable Labs, although today I think everything's pretty remarkable. I think we're having a great time doing this. I hope the fact that a lot of people are signing in is very encouraging, that we're doing something that's important here. And our big plan is to start looking for someone to start doing some liver chemistry tests, because people have a difficult time with liver chemistry tests. Then after that, we'll probably get into rheumatology and infectious disease. So it's not just going to be BMPs and CBCs all the time, but we do plan to have Dr. Jory May back, because I had very high expectations and she exceeded them. She was just so good last week. So I
loved that talk.
We have a guest from my alma mater. He thinks he's at VCU, but I graduated from MCV. That's really the same place. Most people at MCV call it MCV still, I think. Except for the application says VCU. So, Dhruv, just introduce yourself.
Hello, everyone. So I'm Dhruv. I'm currently in M4 now at MCV, or as we now call it, VCU School of Medicine. I am currently in about a week of off time from clinic and prepping for step 2, and Dr. Centaur, Dr. Carter, and Dr. Roland graciously invited me to be the first non-UAB resident to be a discussant on this. So thank you, everyone. I really appreciate it. And
I think I'll call you Dr. Carter today, Sean. I could call you Carter's Little Liver Pills. Livy, introduce yourself.
Hi, I'm Livy Hudson. I'm a PGY2 at UAB, and I went to medical school at Michigan State.
Excellent, excellent. Okay, Stephen and Dr. Carter, take it away.
Yeah, great. So before we begin, Sean was just going to quickly. Dr. Carter was going to quickly review the last case, and then we'll get rolling.
Okay, so I'm never going to let you guys hear the end of this. So last week we had an anemia case with Dr. Jory May, and it was a gentleman who came in with abdominal pain, had high RDW, and kind of did the pump fake, making everybody think about iron deficiency anemia, but it really reinforced that you need to be checking a reticulocyte count so that you're knowing if a bone marrow response is appropriate or inappropriate. His was up, so his bone marrow was working. He was hemolyzing because he had diffuse large B-cell lymphoma, which was kind of a surprise at the end. So Stephen, take us away.
Yeah.
Well, I would just like to commend the team, and I had nothing to do with it, but the team wrote a wonderful tutorial on how to diagnose the autoimmune hemolytic anemia and why you use the reticulocyte index versus the absolute reticulocyte count if you're trying to figure out if the bone marrow response is adequate. And it was just beautifully done. So I just want to applaud the Chiefs for doing that.
Thank you. So we'll go ahead and get rolling. So today our patient is a 30-ish-year-old woman who is deaf. Who comes in with 1 day of weakness. You get her BMP, and it shows a sodium of 138, a potassium of 1.6, chloride 117, bicarb 9, BUN 18, creatinine 0.9, and a glucose of 108. So a lot going on in this BMP, and I will leave it to you, Dhruv and Libby, to kind of give your thoughts. What's your first impression?
Livy, if you want to go start off first.
Certainly the big thing that stands out to me is the hypokalemia, being the potassium being 1.6, and the congenital deafness as well. Also, her bicarb is 9.
Yeah.
So,
So,
so now you have to add up the anion gap,
yeah,
which means you have to do math.
I got my calculator out. See.
that's a gap of about, yeah, a gap of 12, which weirdly enough is normal.
Yes.
So
Yeah.
it's probably normal. Let's just, we've done this before, but in order to know what the normal gap should be, what other,
Oh, right, we need an albumin.
we need an
Forgot
albumin.
about that.
Do we have an albumin, a great leader?
Yeah, her albumin is 4.1.
Okay, so she has an absolutely normal gap.
Mhm. So I think the other thing that I guess I would just go into is just thinking, since I'm in the process of studying for STEP, talking a little bit about congenital deafness and issues with hypokalemia makes me think of weird, like potassium channel genetic deficits. I'm trying to think of what ones that I have seen or heard of in the past. But I do know that there are some arrhythmias that can manifest with congenital deafness and specifically abnormalities in potassium. So I'd want to get an EKG on this patient. Oh, right. Renal and Longy-Nielsen. Yeah. Thanks for reminding me, Jamal. So yeah, I'd want to get an EKG on this patient and see exactly what her heart is doing.
Let's go back to the BMP for a second. Is there anything else that might be a clue?
Maybe like, does she have a azotemia?
Well, it's interesting. Yeah, the BUN to creatinine ratio is very interesting. I mean, it is 20, so you wonder what's been going on. So,
Right.
Right. Yeah.
what's the first question you think I want to ask about past medical history?
Medications?
Oh, right, meds.
Actually, has she ever had it before? Has she ever had an episode like this before? Is this the first
right.
episode? So, Stephen?
Yeah, so this has happened once before, where she has gotten weak all of a sudden, lasted about a day, and then got better.
So let's take a side tour to hypokalemic paralysis, because that's what this is hypokalemic paralysis. She was perfectly fine, and all of a sudden, she lost control of her body. Right? Is that correct, Stephen?
Yes, sir.
So there are 3 buckets with hypokalemic paralysis that you have to think about. This is one bucket. What bucket is this? Now we don't have a blood gas, but we almost don't need a blood gas. So why don't we need a blood gas? I mean, I'm happy to have one, but why do we probably not need a blood gas? Well, why do you get low bicarbonates with a normal gap? It has to be one of 2 things, right?
Either you are breathing hard or you are...
Right. So it's either compensation for respiratory alkalosis or it's a metabolic acidosis. I'm sorry, a normal gap metabolic acidosis. I have seen low bicarbs from severe respiratory alkalosis, and the lowest I've ever seen is 17. It just doesn't get down to 9. So that has to be some kind of an acidosis. So one bucket is hypokalemic metabolic acidosis, and we'll get back to that bucket because that's who she is. I had a patient come in with potassium similar to this. He became paralyzed overnight. He had a bicarb of 32 and hypertension. What would that be?
Yeah. Sorry, he had hypertension.
He had a long history of hypertension, and he had severe hypokalemia with, and we documented with blood gas, a metabolic alkalosis, very significant metabolic alkalosis.
Hyperaldo?
You know, if you watch the chat, you'll get most of the answers right. And he actually did have a adrenal adenoma that was hyperaldo that was removed. You could get it. Somebody said something about licorice earlier, but you could get it with licorice, and it has happened with licorice. It does happen when you do PEDS, Dhruv. You might see infants and babies who have it because they're a congenital adrenal deficiency.
Congenital adrenal insufficiency or congenital adrenal hyperplasia.
They can give you that. Then you could have an absolutely normal bicarb. So that's the metabolic alkalosis bucket. We got the metabolic acidosis bucket, and then we have the absolutely normal acid-base disorder, but you still get hypokalemia. What's that called?
Yeah.
So as soon as I say it, you're gonna go give yourself one of those. For those people who can see me, it's hypokalemic periodic paralysis.
Yeah.
Right? And it wasn't that complicated, except for you weren't thinking in that way. So that's why I'm trying to get you to think of these three buckets for severe hypokalemia. And who gets hypokalemic periodic paralysis?
These are the patients with weird channel.
Yeah, like some sort of like a renal tubular dysfunction.
Yeah, so I don't know that it's a renal tubular dysfunction. I think it's a cellular dysfunction, and it happens, I think, more in Eastern Asians. Although there have been some, we've seen some cases from Mexico, and then Rob throws out sometimes you're more likely to see this with thyrotoxicosis. So those are the three buckets. So let's get back to our bucket. In order to figure this out, are you willing for me to give a little lecture on normal gap acidosis? That sound okay?
Yeah, I would love that.
Okay. So normal gap acidosis occurs because of one of two reasons. It occurs because we're losing a lot of bicarbonate. Now, how would we lose a lot of bicarbonate?
So an RTA would be 1.
Which RTA?
Type 4?
Wrong. That was immediate feedback, Dhruv. In case you ever wondered if you got
Type
feedback.
2.
You got feedback. Type 2. What the
2.
hell's type 2?
I don't know. Let's try to guess the other ones.
Okay. Why don't you use adjectives instead of numbers?
I don't. So the question is, where is bicarb reabsorbed?
The
Right.
proximal tubule.
Proximal tubule. So proximal tubular deficiency. So proximal RTA. In adult medicine, why would we see a proximal RTA? And we see it every now and then. There's a particular drug that'll do it.
Acetazolamide, Diamox.
Well, you could get it. You'd have to take a lot of acetazolamide. You'd have to take a lot of acetazolamide. There's a drug that actually will cause Fanconi syndrome. Remember, Fanconi syndrome is proximal RTA. And so we're getting deep into the weeds. Is that okay that we're getting deep into the weeds?
Totally fine.
Okay. So Fanconi syndrome, remember, is phosphaturia, aminoaciduria, glycosuria, and decreased bicarbonate. I know you heard that once. And I actually had a patient admitted to me with the old formulation tenofovir. The newer formulation is much less common. Gerline mentions tetracyclines, and that is what you'd worry about in pediatrics. And that's one of the reasons you don't do it in pediatrics. I don't remember reading any case reports in adults. But tenofovir is something to think about. You could get it from enough acetazolamide. And Anne-Marie suggests that valproic acid could do it. I always think about valproic acid as a cause of hyperammonemia, but I guess it could also cause a proximal RTA. And I'm sure there are other things that cause it, but tenofovir is the most famous one. Okay, so, but what's the other major way we lose bicarb?
Diarrhea.
Diarrhea. And that's the most common cause for normal gap acidosis in the world because of what disease?
Cholera.
Exactly. So there's both a lot of potassium and a lot of bicarb in stool. So a possibility here would be that this patient had so much watery diarrhea. Now, we rarely see enough diarrhea for diarrhea itself to cause a normal gap acidosis. But if they also have some chronic kidney disease, it becomes very easy, because as we go through why you get an acidosis with chronic kidney disease, you'll see that they don't have very much buffering power, because either we're losing bicarb or we're not able to buffer our daily intake of bicarb.
Mm-hmm.
So this is a great trivia question. We'll see if anybody comes up with in the chat, because the chat is going crazy and I love it. So how much acid do we eat approximately each day that we have to buffer? And the chat is quiet.
I'm trying to think of like how to even put what units I should put that in. I don't even know.
Okay, so I think this is an interesting number to know. It's approximately 1 milliequivalent per kilogram per day is in a normal diet, and that's most normal diets.
Mm.
So that just gives you an idea that, so I'm about an 80 kilogram man, so I'm going to have to, I have to have enough buffering for 80 milliequivalents.
Mm.
We buffer in two ways in the kidneys. There's two ways we buffer. So we're getting deep into renal physiology. If anybody breaks out in hives, it's an anamnestic response.
Mm-hmm.
And it's okay.
Wishing that Dr. Toff was here.
Okay, so it's mostly phosphates, and that's called titratable acid. And the phosphates are pretty steady from day to day. Our body can't control how much phosphates there are. What our body can control is how much ammonia we make. So I'm going to take you through this, and then if we don't already have a picture of this, we will develop a picture and put it up on Twitter and show it next week. In the proximal tubular cells, so now we have to go back to biochemistry. Glutamine goes to glutarate. And when glutamine goes to glutarate, and the enzyme is glutaminase, it produces ammonia, which goes in the proximal tubule, immediately gets protonated to ammonium. Remember, ammonia is NH3, ammonium is NH4+.
Mm-hmm.
Have I made anybody dizzy yet? Okay, we're doing good so far.
We're doing good.
Then the ammonia goes down, and when it gets to the sodium potassium 2-chloride cotransporter, the ammonium is a small cation, so in that transporter transports it into the interstitium. It goes, once it gets into the interstitium, becomes part of the countercurrent mechanism. So you have a lot of ammonia in the medulla and less ammonia in the cortex. And then from the ascending loop of Henle through the distal convoluted tubule until you get to the collecting system, there's no ammonia. Then ammonia comes back in by passive, just forgot the word. It crosses the barrier.
Diffusion.
Passive diffusion. Thank you, Rob. And If we have acid urine, then we protonate it. It's a true buffer because we have microequivalents of acid, and that gives us milliequivalents of ammonium. Okay, has everybody got that? So how can this go bad? One is you could have chronic kidney disease. She does not have chronic kidney disease. It would have to be at least 3B and probably 4. If you have chronic kidney disease, you have less proximal tubular cells, so you make less ammonia. And then remember, when you get chronic kidney disease, you start to wash out the countercurrent mechanism. And the reason is because you have to have extra flow, and it's very flow dependent. That's the only thing I can remember about the countercurrent mechanism. But you have less ammonia there, so you can just handle less ammonia as your kidney function gets worse. So that's one possibility. It's chronic kidney disease. That can't be it in this case. The second reason is because you have hyperkalemia. Well, we know it's not hyperkalemia, but that's, Dhruv, you can recover now. What is hyperkalemic metabolic acidosis called?
That's type 4 now.
That's type 4. And for years, I didn't know what this meant. And one of the nephrologists at our VA, Dr. Balkovitz, explained it to me one day. It turns out that where we're making the ammonia, the glutamine to glutarate, the enzyme is glutaminase. And high potassium inhibits that enzyme, so you make less ammonia. So the reason you get a metabolic acidosis is because you're making less ammonia. And remember, that usually only happens when you also already have some chronic kidney disease, because you don't get the type 4 RTA with people with totally normal kidneys. Now the obverse is true. So if you have low potassium, you make more ammonia. And that's the reason that low potassium is a risk factor for hepatic encephalopathy.
Oh, okay.
You might have memorized that before, but you never knew why. It's because you actually are producing more ammonia. And that's why that's one of the reasons we use spironolactone as one of our main diuretics when we treat ascites in hepatic failure.
Mm-hmm.
The last reason would be that we can't acidify the urine. And what's that called? You can either give me the adjective or the number.
Let's see.
We've
already done 2 and 4, and 3 doesn't exist. I'll give you a clue.
That's type 1.
So it's type 1 or distal RTA. So remember, there's a variety of distal RTAs, but they all have in common, you can't acidify the urine. If you can't acidify the urine, then you lose that whole buffering stream. That makes sense?
Mm-hmm.
And so every day, let's say I'm eating 80 milliequivalents of acid a day, and I have enough phosphate to buffer around 40. That's a rough number. The exact number is not important. That other 40 that my ammonia should be taken care of, if I can't acidify the urine, that means I have 40 milliequivalents of acid I haven't gotten rid of, and my bicarb goes down, and it goes down, and it goes down, and it goes down, and it goes down. So how are we going to, which one is likely? So we know it's not type 4. This can't be type 4. You can get hypokalemia from proximal RTA. So that's a possibility.
Mm-hmm.
It's not chronic kidney disease. So we're sort of stuck with, is there diarrhea? Is there a distal RTA? Is there a proximal RTA? Or does she have some other reason that would work like a distal RTA? And someone had mentioned before urinary diversion or a pseudo bladder, so to speak, after bladder cancer surgery. When you think about it, if you have too much dwell time, when the urine goes in this artificial bladder, which is usually some ileum, it's usually called an ileal conduit, then what happens is If it stays there too long because it's not a tight junction, it can't maintain that pH gradient. And so it's exactly like a distal RTA. Does that make sense?
Mm-hmm.
Okay, so we need to get a diarrhea history. And if it's a distal RTA, what is going to be what is the urinalysis going to show us?
The pH would probably be up.
Yeah, it should be 7. It should be 7 or 8 if it's a distal RTA. Now, I will tell you that this is probably is a distal RTA because it's a classic presentation of the distal RTA. What we don't know and have to look up, and fortunately we don't have to look much up because the chat room is so smart, is what kidney disease are associated with congenital deafness that also cause distal RTAs, if that's such a thing. But what we really need now is a urinalysis. It'd be nice to have a VBG or an ABG, but it's not 100% necessary.
Sure. So I can answer all those questions for you. As far as diarrhea, she has not been having any diarrhea in the past few weeks. She did get a VBG, which showed a pH of 7.16, PCO2 of 24, and a bicarb of 8. And then you guys also wanted a UA that showed a pH of 6 with a specific gravity of 1.006 and 1 plus protein and 1 plus blood.
Okay, so let's just do the VBG for the heck of it. Let's just see whether or not she's compensating appropriately. And so this is sort of interesting. She might not be able to compensate completely because she has muscle weakness now. And so she might not be able to have as brisk a respiratory response as you need. And her numbers, so her bicarb was 8 on the
VBG.
on the
Yeah, 8 on
VBG.
VBG.
Okay, so how do we figure out whether that's the appropriate respiratory response? You're
Is
doing
this
math,
one
Libby?
we do Winter's formula?
Yeah, Winter's formula.
Okay. So then it's 1.5 times the bicarb plus or minus 8 plus or minus 2. Is that the?
Wait a second. Wait a second. I just clapped for you. If you look at my screen, I just clapped for you.
I see it. Thank you.
Here's the trick. If you ever have a patient admitted to you, you have to use the VBG or the ABG bicarb, not the BMP, because there's a couple of reasons for that. But the original study was just a blood gas study, and Dhruv was actually a pediatric study. It was in the Annals of Internal Medicine, but it was a group of children who had congenital metabolic acidosis. And that's where they came up with the regression equation. So if we do the math, and I'll do the math for you all this time, 8 times 1.5 is 12, plus 8 is 20, plus or minus 2. She's not quite ventilating. We'd expect her to be around 20. She's at 24. Maybe she just can't breathe, but so hard. I wouldn't be worried about that. But it may be that she may be a little bit more acidotic than normal. Now, before we figure out exactly why she has this, this is definitely a resident question, not an intern question. Are you going to give her bicarb?
No.
No, I wouldn't think so.
The answer is 100% yes.
Yeah.
And I have a wonderful article that I will share with the chiefs. You always treat a normal gap acidosis with a goal of 22. You always treat a normal gap acidosis. You almost never treat an anion gap acidosis because you want to treat the underlying disease that's causing this. But this is a true bicarb deficiency syndrome. So you have to give bicarb to this patient. How would you decide how much bicarb to give her? Okay, let's figure out what her bicarb deficit is. Approximately what's her weight, Stephen?
She's 70 kilos.
70 kilos. Okay. So what's the bicarb space? So we're going to walk through this so that maybe it'll ring a bell sometime in the future. Okay, you learned the bicarb space once in physiology, and you said, I know nobody's ever going to ask me that again. So it's approximately the total body water, which is about half of your weight is water, because bicarb's small and it diffuses everywhere. It's in the interstitium, it's everywhere. Okay, so let's say we have 35 liters, and her deficit, the magic number that we use for all bicarb corrections is 22. So her deficit is 14. So we multiply 14 times 35, and that's how many milliequivalents she needs in order to get back to a bicarb of 22. How are we going to do that? So Dhruv, you're an intern next year, and this patient comes in and you want to start trying to correct her bicarb. And you don't really have to correct it immediately, but it'd be nice to get on the way. So how are you going to give her bicarb?
So I'm trying to remember how much an ampule of bicarb has. I think it's like 20 milliequivalents.
Go higher.
50.
50. Okay.
Livy's right on target. So it's 50 milliequivalents in an amp. Okay, so how does that help us?
And her bicarb deficit is around, so it's 500 or so. So, yeah. Which essentially means that she's going to need 10 amps of bicarb in order to fully correct it.
Over a couple days, probably.
Over a couple of days. So,
and she may be a little volume contracted. Now, what was interesting is with this BUN and creatinine, her urine-specific gravity was 1.006. He didn't even write that down, and I don't know why I remembered it, but you know why I remembered it, because I love
that graph, right? So hyposthenuria, then, I would think.
Right. So, but how do we give bicarb? So this is an intern lesson.
So we usually do the 3 amps in D5. At least I'm pretty sure Tolwani said that that's an isotonic solution. And
I agree 100% with Dr. Tolwani. That's what I would do. Is I would get a liter of D5 and W, and add 3 amps of bicarb to it, because we don't need to give her any more chloride. She's got plenty of chloride. We really need to give her bicarb. So that'd be about 150 milliequivalents. And if we gave that slowly over, gave 2 liters over the first day, she'd be going up quite nicely. And then we can give more the next day. But then we're going to have to figure out why she has it, so we can figure out how we're going to keep her from doing this again. What about the potassium? How are we going to give her potassium? And how fast we give her potassium?
I mean, I guess you could put it, you could give her IV. I'm not sure what her status is as far as, can she take it in? Can we just give her oral solution to help beef up her potassium numbers? But I guess you could also run it IV.
Right. So the question is, and this is a really important intern question, is how to give IV potassium and then how to give oral potassium. She has a huge potassium deficit. Okay, let's go over potassium deficit. To go from 4 down to 3, that's somewhere in the 100 to 300 milliequivalent range. Remember, potassium is mostly intracellular. To go from 2 to 3 is another 300 to 500 milliequivalents. And then she's down at 1.6. I mean, she's probably 500-600 milliequivalents total body down. But we can't give it too fast, can we?
No, because you'd basically be shocking the heart.
Yeah, you can mess up the heart really badly. So I'm going to tell you the rules that I use. If the patient is going to be on the floor, we can give 40 milliequivalent orally several times a day, and we can give 5 milliequivalents IV if we have a large bore IV. If you're in the unit, you can go up to 10. if the patient looks like they're dying and they're in the unit and they're being monitored and you had 2 IVs, you could go up to 20, but I've never seen that done. So you really, really want to give low dose. Vikram wants a tutorial. We will come up with a tutorial on this. Okay, so we'll start giving at least 5 millicoulombs per day and hope we can give her something orally. She has global paralysis, but if she can take oral, that's the best way to try to replete it. I probably would check a phosphate also, just because I'd hate for her to also have hypophosphatemia. I don't know if you had checked a phosphate on this one, Stephen.
Yeah, her phos was 3.
Yeah, and it may go down as we give her glucose. So it's going to be dangerous. It depends on how well she's been eating, but it could be dangerous when we give her glucose. So Travis suggests K-phos. We have a hard time getting K-phos, at least at the VA. Pediatrics always uses K-phos, and that's really, really good for IV. And you'll notice that in DKA, in pediatrics, they always give K-phos, and in adult medicine, we're not smart enough to do that. But I just keep that in the back of my mind. I would check the phosphate the next day.
And now, one more thing, Stephen, the MAG. Did we get a MAG level on her as well?
Yeah, her MAG is 1.8.
Okay, that's a great question. Why'd you ask that, Dhruv? Because I really like that you asked that question.
I remember from experience, I was treating a patient, and she was had a weird congenital fatty acid transporter deficiency, but it ultimately caused her to have massive amounts of diarrhea, and she was TPN dependent. And I believe in refeeding syndromes, you deplete MAG, so you have to adequately replace it. And it also, MAG, I think, also influences levels of calcium as well, if I remember correctly.
That's correct. So
hypomag prevents you from getting calcium levels normal.
It would be nice to have a calcium level also.
Right.
Yeah, calcium's 8.9.
Okay, that's pretty good calcium. So here's the problem with MAG, and somebody sort of alluded to it. They didn't say it directly in the chat room. If you have resistant hypokalemia, you have someone coming with hypokalemia and you give them a lot of potassium and they're not moving anywhere, even if their MAG is normal, you just empirically give them MAG. Now that is mostly in alcoholics, because alcoholics have waste MAG. So a normal MAG does not rule out total body magnesium depletion because it's intracellular. So thinking about MAG, Dhruv, is outstanding. It doesn't really fit with the hypokalemic metabolic acidosis, but it's always a good thing to think about. That tends to be more an alkalosis or just a pure, you'll see alcoholics come in with a MAG of 2.5. And you keep giving them with potassium at 2.5, and you keep giving them potassium, it's not moving anywhere until you give them MAG. But the other thing that you mentioned is really spot on, is you also look at the calcium. And this is a normal calcium with that albumin. So the patient is going to need a lot of potassium, but we're going to titrate it. We're going to give potassium slowly and keep checking it. The patients that I've seen get better pretty fast once we start giving them potassium. Now, in general, in adult medicine, what's the most common cause of a distal RTA? And this defines a distal RTA, right? We have a urine pH of 6 when it should be 4.5 or 5, right? So she can't acidify her urine. What is and it's been mentioned in the chat several times, but there is a disease on the test. And this could be a step question, and it could definitely be an internal medicine board's question.
We've got
and the chat does not have this one.
We've got a Bactrim.
So Mario bring up Mario's chat. So it's usually autoimmune disease, and far and away the most common is Sjogren's syndrome. So we're going to go back and ask her about dry mouth and dry eyes and stuff like that. Now, there are other things that will cause a distal RTA. Amphotericin, if she'd been on amphotericin, you can get a distal RTA. And I think that with congenital deafness, I know there's some congenital deafness renal syndromes that I don't know the answer to, and I'm going to quickly go look those up. If she doesn't,
I got it right here. Actually, there is one.
There is one.
It's the vacuolar proton ATPase. It can get there are two genes that can get mutated, and it causes distal RTA and deafness.
And the fact that she's had it before would mean that we'd actually have to think about that.
Right.
So we'll ask the Sjogren's questions, and we'll look for dry mouth and stuff like that. The fact that her urine osms are 1.006 would make Sjogren's a little bit more likely, because those people tend to drink a lot of fluids because their mouth's so dry. I had a case presented to me a few years back where the clue was the lady was drinking 4 liters of Coca-Cola a day, and everybody's trying to figure out the acidosis from the Coca-Cola. And I said, why is she drinking 4 liters of Coca-Cola a day? And he says, because her mouth is always dry. So I would be suspicious of Sjogren's because her urine osms are low, and therefore she's probably drinking a lot of fluid. And so I would think about that. Now, she's not drinking.
Although you did wait 1 second though, Uncle Bob. You said 4 liters of Coke, right?
Yeah, that's a lot of phosphate. That's a lot of phosphate. But phosphate's not going to cause an acidosis.
True that.
It should help you buffer. So let's go back and ask the questions about, and I don't think diabetes does this. People were asking about that, but I don't think that diabetes causes type 4 and it causes chronic kidney disease, but usually it doesn't. I don't think it causes the distal RTA. So if we ask Sjogren's questions, what do we find out?
Yeah, so she does not complain of any dry eyes, dry mouth, no autoimmune diseases that run in her family, no numbness or tingling. Any other symptoms you wanted?
I'd send off the tests for Sjogren's. I'd send off the autoimmune tests, but then I'd also talk to my genetics people and see if there's a genetic test for this. Anne-Marie gave us the name of it. I was really impressed, Anne-Marie.
Yeah. Stephen, I'd also ask about. Yeah. Stephen, I'd also ask about vaginal dryness as well.
Not a complaint that she had.
Okay. So I think it's one of those two things. Now we're going to treat it the same way in the short run, but then we're going to have to figure out how to treat it in the long run.
Yeah. So I think you guys really from the beginning had a sense of what was going on, and once you got to the end, you guys pretty much nailed it. In fact, I think both genes that cause this issue are named in the chat. So she has a rare genetic disease that causes both congenital deafness and a distal RTA. Anne-Marie had mentioned there's 2 genes, ATP6V08. I'm not going to read them both, but there's 2 genes that are involved, and she actually has the first one, the VOA4 gene, which encodes a proton pump.
Okay, let's finish with trying to figure out how we're going to keep this from happening again. How are we going to keep this from happening again?
Lots and lots of
Give her
bananas first.
spironolactone.
All right, spironolactone would be enough.
So the spironolactone is going to help with the hypokalemia. Okay, so we could give her spironolactone or a miloride. That would probably help. Follow her potassium levels and make sure that her potassium's staying okay. How are we going to prevent her from getting acidotic again?
Scholl's solution.
Okay, so Scholl's and Bicitra are the same things, and can you explain what they are?
No, not off the top of my head. I mean,
Sodium citrate.
Oh,
right,
just
right, because citrate alkalinizes the urine and
So
doesn't require bicarb for it.
so how does sodium citrate work? Because that's one of two things we can do. How does sodium citrate work? So remember the Krebs cycle? I'm not going to explain the Krebs cycle. I can't. The only time I ever knew the Krebs cycle was the night before step 1. I turned to the first page. There are 25 questions on the Krebs cycle, and I said, I'm going to pass step 1 because I knew a cold that day. So
is sodium citrate, is it metabolized into bicarb by the liver?
100% correct.
Okay,
Beautiful.
Tolani.
Can we get a lot of claps for
CRT.
Olivia on that one?
That, I gotta
Everybody
give
get the
credit to
clap.
Tolani on that one too. That's the CRT, the whole pathophysiology on that.
Right. So sodium citrate works. What's the problem with sodium citrate?
Could you try again?
Sorry. My watch is.
So what's the problem with sodium citrate if you're going to talk to patients?
Like in general or for this patient?
For any patient, it tastes horrible.
Oh.
When I was an intern, we had to taste it. Have you ever had a vodka gimlet? You know what a vodka gimlet is? Lime juice.
Yes.
You know what lime juice is. So imagine pouring out a cup of lime juice and then pouring a whole salt shaker into it. That's what it tastes like.
Oh, that sounds disgusting.
It is disgusting, and most patients don't like it. So we could give sodium citrate. How much would we need to give, approximately? And remember, we're going to titrate.
I mean, I feel like I usually will start with 30 TID and then see how they do.
Okay, 30 TID is going to overcorrect her. So once we get her back to normal, remember I told you that we have to buffer about 70 milliequivalents per day, and her phosphate can do most of it. So 30 cc's a day is probably enough.
Okay.
Probably enough. How else could we give 30 milliequivalent? And it's 1 cc per milliequivalent, 1 milliequivalent per cc. So when you give 30 cc's, that's 30 milliequivalents. What else could we give?
Like sodium bicarb tabs?
Right. Or cheaper yet, and Vishnu put this in the chat, baking soda.
Just baking soda itself.
Yeah. And I forget how many milliequivalents are in a teaspoon. Do you know, Travis, since you're on the chat? Okay, we'll look that up for the tutorial. If you were going to give tablets, in order to give 30 milliequivalents of tablets, how are you going to give it? Does anybody know? No, nobody ever remembers that. Okay, there's two sizes of bicarbonate tablets. There's the 625 and the 1350. And the 625, no, 650 and 1300. So the 650, I'll spare you the math, is 7.7 milliequivalents. So the 1300 is about 15 milliequivalents. So if they can tolerate bicarbonate tablets, sometimes that's easier is to take 1300 twice a day. And you'll see that ordered all the time from Renal for people who have chronic kidney disease and acidosis. And that we don't have time for that part of the lecture. We'll do that some other time. But the cheapest way to do it is sodium bicarb. So somebody said that there was 47 milliequivalents in a teaspoon. So you really don't, so a tablespoon has 60 milliequivalents. So it's a half a tablespoon. So a teaspoon, and if you can get them to take a teaspoon a day and then go back and check, you can probably keep the bicarb and keep them from getting so acidotic and so hypokalemic, and keep her from having global paralysis again.
So you guys were right on the money. So nephrology recommended starting her on spironolactone and sodium bicarb. She got better with potassium and bicarb in the hospital, regained her function, discharged, and so far hasn't had a recurrence. So thank you guys for curing her. I appreciate everyone walking through this. At this point, I was going to let Seema kind of give her thoughts and wrap up the important points from this session.
Yeah, so we definitely talked about a lot in this session that you can always review once we post this episode and check for a tutorial later in the next week. But just a couple of the big highlights from our conversation. So there's 3 big buckets of severe hypokalemia. So you want to think about hypokalemic metabolic acidosis, metabolic alkalosis, and normal pH. When you're using Winter's formula, remember you want to use the ABG or VBG bicarb level, not your serum bicarb. In treating, or when you have a patient with anagma, remember that that is a true bicarb deficiency and you're always going to treat that. When you're get to the point of using bicarb, remember that there's 50 milliequivalents in an amp of bicarb and that you can calculate the amount of bicarb needed and use that to get them the correct dosage. If you have resistant hypokalemia, even if your MAG is normal, especially if you're working with an alcoholic, a patient who is an alcoholic, make sure that you remember to still give them MAG, even if that's originally, if that number is normal. In general, in adults, the most common cause of a distal RTA is Sjogren's syndrome. And finally, when you're trying to replete the bicarb and maybe your patient can't get access to or afford Scholl's solution, sodium bicarb tabs, remember you can just get them that teaspoon of baking soda. Much cheaper, gets the job done.
Because we have 2 minutes left, is Dhruv still here?
He is. He just accidentally screwed with his Zoom meeting and had to.
That's okay. So Dhruv, what's the most important thing that you learned from doing this? And we really appreciate the great job that you did helping us today.
I think the big thing that I learned was just in general the idea of once you have the idea of if you have a normal anion gap metabolic acidosis, you treat the bicarb. Most of the cases that I've seen in the past on Unremarkable Labs and others were cases of anion gap metabolic acidosis where bicarb was the wrong answer, and this was the one example where it actually is the right one.
Livy, what's your big take home?
I actually, Dhruv totally took mine because that was just like a great reminder, but I really appreciated what you had to say, Dr. Centaur, about some of the nitty gritty micro like biochemistry stuff, like the increase in the potassium inhibiting the glutaminase, and then that like leading to decreasing your ammonia, how you did a really tie-in with hepatic encephalopathy. I thought that was like just, I love stuff when it makes sense. So that was really helpful for me.
Well, thank you, Chiefs, for giving us a nice challenge today.
Glad you guys enjoyed it. So thank you for coming and working with us today. As always, thanks to our discussants, Livy and Dhruv, for being here.
Yeah,
And
great job, Dhruv.
Thanks, and same to you, Livy.
We look forward to seeing you guys next week.
Livy, great job.
Thanks.
Bye, guys.